So at this meeting, we had a really provocative session. We looked at one frontline study, those we mentioned, VELIA, and then we had two maintenance trials, the PAOLA-1 trial and the PRIMA trial. And it's really hard to actually fit them in together, from that standpoint. But you can look at the PRIMA study and the PAOLA-1 study as trials that were trying to address a quite slightly different question. And that's the question, you had a patient who finished their frontline therapy, and now we're trying to figure out what's the best opportunity to continue to maintain them in hopefully a complete response state for as long as possible. And so those two trials kind of follow on the heels of what happened here last year, which was the presentation of using olaparib in a biomarker-defined patient population, so-called BRCA mutation, germline and somatic tumor cases. And that study showed that it was able to extend progression-free survival substantially. So these two trials were looking slightly different questions, but essentially looking at the same patient population. And very fortunate for us and for the community, we were able to show that the use of niraparib was actually very efficacious in reducing that hazard for progression in patients that were actually relatively poor prognosis. So they had high degrees of disease at the completion of their surgeries. And then in the PAOLA-1 trial, actually looked at the addition of a PARP inhibitor onto bevacizumab, trying to capitalize on some previous evidence there. So both those trials showed a significant improvement in progression-free survival. So VELIA also showed that, but it started at a different time point. So it's hard to put them directly into context, but the good news is that in a biomarker-defined patient population, and we can talk about what that is, germline, HRD, somatic mutations, that patient population seems to benefit from a PARP, and that's really going to change the narrative about what we do with that group of patients.